May I invite Dr. Pradeep Rebala for PSRS stepwise approach, please.
So good afternoon, Chairpersons and friends. Greetings from Asian Institute of Gastroenterology, Hyderabad. And I'll be talking on the technical aspects of the proximal splenorenal shunt. And traditionally, it used to be a very common procedure. Nowadays, because of the aggressive endoscopists and interventional radiologists, the indications for surgery has drastically come down, but still you will encounter situations where it requires. Most important is, apart from the cross-sectional imaging of locating whether the size of the vein, you have to prepare the patient by restoring the blood volume, correct all the deficiencies. We use a prophylactic antibiotics, control ascites. We routinely give prophylactic immunization for these because these patients undergo a splenectomy. But though some centers in India do not use this, particularly in Indian patients. And the position we routinely place slight elevate the left side of the patient, and we produce a little bit of hyperextension or a sandbag under the loin. So to make the access to the particularly the renal hilum much more easily for accessibility. And then we use a left subcostal incision is what we routinely use. And if required, you might extend onto the right side because of the patient's configuration. You can have a better access to the pancreatic body and tail pancreatic region. And always use a cautery because a lot of collaterals there, so they should be ligated and divided. And the retraction, good retraction, a Thompson retraction is what we routinely use to lift the costal margin. You retract the colon downwards, and you have to expose the whole of body and tail of pancreas, including the lower part of the hilum of the spleen. So this is what the approach should be for before you start dissecting. And first step would be to retract the stomach. You disconnect the short gastric vessels and also ligate the vessels and lift the stomach up with a self-retaining retractor of the Thompson. And you incise the lower part of the peritoneum on the lower border of the pancreas and get into the correct plane. And usually, in spite of so many collaterals, this plane is avascular. You can comfortably mobilize the splenic flexure down and you go behind the pancreas without much of encountering any difficulty with the collaterals. So this is the most important, the first step to work in an avascular plane before you reach. And this extent of dissection is up to the superior mesenteric vein. And once you mobilize this, then you will encounter small tributaries reaching from the pancreatic undersurface of the pancreas to these. These vessels have to be ligated by fine sutures of 3-0 or 4-0 silk and then divided between the sutures. We don't use any energy devices for these. So a good suture technique is more important and adequate length is mobilized. This is the video which shows we have after exposure. This is the hilum of this spleen, and we are after this in continuity ligation of the splenic artery, then we're working on the splenic vein. We dissect predominantly more distally as close to the hilum, so in order to achieve as much length as possible. So you can see this, the division of the splenic vein into the superior, one branch into the superior pole and one branch into the inferior pole, and that is the level at which we start transecting this splenic vein at the tributaries level. So the aim is to achieve as much length as possible at the time of dissection. Subsequently, it can be trimmed. And you can use energy devices in areas where you don't have large tributaries. All the vascular tributaries or venous tributaries should be ligated rather than using any energy device. So that completes the mobilization of this vein or transection of the vein at the hilum. The aim is to achieve as long the splenic vein as possible. So first step is to remove the spleen. So once the spleen is removed, which is usually very large spleen, then you have enough space to work on the undersurface of the pancreas. So now you leave a lot of long threads there for your assistant to put a traction so that it will minimize any injury to the splenic vein in handling it. So the handling of the splenic vein should be as minimal as possible. And then these are the small tributaries which actually, the multiple tributaries which actually come from the pancreas and join the splenic vein. All these tributaries should be meticulously dissected without injuring any of the splenic vein. so that an injury can lead to thrombosis or which can happen immediately after surgery. So the handling of the splenic vein should be as delicate as possible. And as you move down, you can use a monopolar or a bipolar. We prefer to use a bipolar so that the collateral damage will be much less in a bipolar, more dissection. So this dissection is usually done using bipolar, and as and when you encounter the tributaries, you ligate it. So we use a hydrodissection as well to open up the planes and then work carefully on the vein. And the extent of mobilization is as much to the right of the patient as possible, that is closer to the SMV. Sometimes we do encounter inferior mesenteric vein. We might have to ligate the inferior mesenteric vein if it joins somewhere in the middle of the splenic vein, which can happen in some situations. So you can see that the vein is adequately mobilized, which can lie comfortably onto the renal vein at the time of anastomosis. So once this step is achieved, the next we move towards the hilum of the kidney. So we expose the hilum of the kidney, the left renal vein is mobilized. So that is where we dissect it at the hilum of the kidney. The gyrotous fascia is incised, and here we use a bipolar and other energy devices to expose the renal hilum and the renal vein. So you do find sometimes these collaterals joining there. Sometimes you can see some collaterals joining even the renal vein tributaries as well. So those have to be ligated and divided so that you can have good length of the renal vein. You can see this renal vein. This renal vein has an anomaly there. It has two branches which is actually branched outside. One branch which is a superior pole is a big branch, so we thought we can use that superior branch, and then you can dissect it off right to the more the extensive mobilization of the renal vein so that it can be comfortably. That is the gonadal vein. You can see the gonadal vein there. So it's not normally we try to avoid ligating the gonadal vein, and on superior portion of the renal vein you can see the adrenal vein. So we routinely ligate the adrenal vein so the renal vein can be completely mobilized freely so that you can do a good anastomosis without any tension on the anastomosis. So this again is divided between the ligatures. So that completes a complete mobilization. You can have a free, the renal vein is completely mobile now. So we have looped up both the branches of the renal vein. So the inferior branch appears to be smaller, the superior branch is slightly bigger. So we tend to use we have used the superior branch of the renal vein. That is the mobilized splenic vein. You have good length of the splenic vein. So we try to shorten the vein so that it lies comfortably onto the renal vein. So now renal vein is clamped, the lateral clamp is done, the Setinsky. Now we have to trim the splenic vein. You reposition your clamp, and then an oblique cut is given so that when the splenic vein sits on the renal vein, it should sit comfortably. So the oblique cut will make there's a heel and a tip of so the heel should sit medial and the tip should go towards the hilum of the kidney. So you take stitches at the corner so that the alignment will be correct. So once you placed stitches at the corner, then you do a venotomy of the renal vein, and then use a pot scissors and lay open adequately, and then first place the corner stitches there using a 5-0 double arm, double needle 5-0 at both the corners so that the alignment is correct. And from one of the corner you start the anastomosis, continuous suture, and reach the opposite end of the corner and then tie the knots outside. So the aim is avoid any adventitia coming into the anastomosis. The endothelium should be anastomosed to the endothelium. So now the same sutures, we bring it forward for anterior suturing. So over and over continuous, and handling of these edges should be as delicate as possible not to damage the endothelium. So use a vascular forceps and do a running suture from one end to the other end. So usually we start from one corner, come to the center, and use the other end from other corner to come towards the center, so that the final knot is usually placed at the anterior row on the center of this thing. So your assistant, when you are following, should not produce too much of traction, which can produce a bursting effect. So you should be careful not to produce this bursting effect, which is detrimental to the final outcome of the shunt. So now the other end, from other corner we started and come towards the center, and then tight the previously placed suture. And in children, we can leave at the end a growth factor for this to expand. So before you place the last stitcher, we just let go the blood so that any air trapped inside will come out. So that is the completed procedures. There might be some small wounds sometimes, which can just stop by just putting a gauze piece around it. But in certain situations, if there's some bleed, which might be one or two sutures there to overcome this. Most of these bleeds will stop by just putting a gauze piece around that anastomosis. And that completes you can see nicely the splenic vein is sitting comfortably without any kink or any tension. So the tips is proper selection of the patient is very important, and position of the patient. You should have a good exposure. You should be in the ideal plane of dissection where you will not encounter any collaterals. Adequate mobilization of both splenic and the renal veins. And during the anastomosis, one should avoid a rotation, kink, or tension or redundancy to achieve a good long-term patency of these shunts. Thank you.
Thank you very much for the nice presentation. Any questions, please?
Good afternoon, sir. I am Dr. Kush Parekh from SGPGI. So one question is that many a times the portal vein thrombosis, the block is extending up to the splenoportal confluence. And at times, intraoperatively, we see that the distal part of the splenic vein can be traced entering into a collateral. In such situations, what would you do? Would you go ahead with a makeshift shunt, or would you opt for a mesocaval shunt?
You should opt for a mesocaval shunt.
Mesocaval shunt. And what is the routine post-operative anticoagulation protocol?
We don't give any anticoagulants unless we know upfront this patient has some deficiencies. Otherwise, we don't use post-operative.
And regarding antibiotics, post-op?
Routine antibiotic, post-operative we don't use. We just use 3 doses of the antibiotics for prophylaxis. Otherwise, we don't use routine antibiotics in these patients.
Okay, I don't think there is any more questions. Thank you very much.
Thank you.